All right. I want to make 3 points here. First of all, in my 40 years of being in medicine, there has never, ever been a better time to get a job in an academic medical center as now. And I'm going to show you that because community practice, private practice, is like the real estate market of 2007. It's headed towards a disruption that we have never seen in at least my career, probably since 1965. The second thing is you are the elite of the elite, okay? You guys have succeeded already, so whatever you do from now on in is really going to be up to your own choices, your own inspiration, your own dedication. You really, the sky is the limit for you, and I really want to emphasize a lot of the points that Keith made. You're in a great position. But the third point is you have to choose your setting very carefully because healthcare changes right now are going to be extraordinarily disruptive. And whether it's in community practice or academic medicine, there are going to be some definite winners and there are going to be some big-time losers. So it's really important. So I want to give you a little bit of a hint. First of all, why academic medicine continues to look good, and then also give you a context about how to think about where you want to land. Okay, so the realities of our world are this. We have an activated patient population. They basically say, don't hurt me, help me, and include me. But the market, I don't know how many of you understand healthcare economics, but we have existed in a world of employer-based insurance. That is completely changing now. It's becoming an individual market. And the implications of that are profound. I could do about an hour's lecture on that, but you have to sort of understand those implications. It is empowering the individual, either individually or through other entities empowering the individual. So you have to really think that. The second is we have a very stressed workforce, provider workforce, but a very dedicated one. But it's not easy. The third is that we're entering a field where, on one hand, we have personalized medicine. On the other hand, we have big data. The research opportunities in those two areas alone are almost unbounded. So you're really entering a very exciting field. And then finally, as Bill Gates puts it, we are in an economic stressful period. Politicians must address tough choices about limited resources. How many teachers are you willing to fire in order to have 78-year-olds have a procedure which will be invented 5 years from now? The economic realities cannot be overestimated. This is the current GI business model of a community practice. It's around 3 CPT codes: diagnostic colonoscopy, colonoscopy with biopsy, and colonoscopy with polypectomy. 40 to 70% of revenue of community practice emanates from those, and all the rest of the stuff is almost a distraction. That puts it in a very, very vulnerable position. So you're making the right choice. That's my point. So practices have to deal with this. And I am going to get into academic medicine in a minute, but I want to lay the groundwork. First of all, when you say the world's like the triple aim, okay? So if you're a clinically integrated network, a big healthcare system, you think about patient experience, population health, efficiency. If you're a practice, you're thinking measurement burden, how do they attribute patients to me, and it's going to reduce endoscopy. If people say right care, right time, right place, we've all heard that stuff. Okay, if you're a clinically integrated network, you're thinking guidelines, access, site of service. If you're in private practice, you're thinking PQRS, quality resource utilization reports, value-based modifier. It's basically discounting your services. Total cost of care. You're thinking deep discounted fee for service, probably a 30% reduction in endoscopy because of waste, and decreased procedures. If you're a health system, I'm on the board of Allina Health, big Minneapolis-based health system. You're thinking clinically integrated network, and if you're in private practice, you're really thinking that's a black hole and I'm going to get sucked into it. Some truth in that. We're operating under 3 big legislative acts, okay? Medicare and Medicaid came about in 1965, July 30th, 1965. That transformed medicine from the realm of personal law to the realm of public law. That made Congress and the Supreme Court the final arbiters of healthcare policy. A sea change in the United States. Since 2009, we're operating under 3 different acts. The first is the HITECH Act. That brought us electronic medical records. Now, that's a good thing, but it also means the market is consolidated. Between Epic and Cerner, they own the large healthcare systems, right? In private practice, there's NextGen, there's GMed, GI practice, NextGen, GMed, a couple of others. Those are consolidating, but what that does is solidify a healthcare delivery network like no legislation could. The second, of course, is the Affordable Care Act, signed on March 10th, 2010. There are a lot of different aspects to that, so there are 10 different titles in that act, but the main things, and I'll go into that the next slide, it mandated that Medicare become the change agent. Medicare before was just a pay and chase, kind of a passive payer. It is now mandated to be a change agent. So we're going to see a lot coming from Medicare. And the second thing is it universalized Medicaid. It went from Medicaid being available to kids and really, really poor people and pregnant women to universalizing it to everybody under 139% of the federal poverty level. That is a step towards the concept of universal health care. And the United States is one of the few countries that doesn't have that now, but that's, again, a sea change from a philosophical standpoint. And then finally, the Medicare Access and CHIP Reauthorization Act in 2015. That is the act that will change our practices. It was passed virtually unanimously by both Democrats and Republicans. It ain't going away, and I'll show you that. The only point I want to make on this slide, which comes from the Wall Street Journal, is as follows. In the lower left, the foundation of the Act rests on three main blocks: the requirement that most Americans buy coverage or pay a penalty, that insurers cover everyone regardless of their medical history and tax credits, and the third is there will be subsidies to help low-income people. That's the foundation. Two of those have been tested in the Supreme Court and passed. And they are embedded now in our healthcare system. Although every Republican runs on repeal and replace, it's enormously difficult to pass legislation. It pales in what it will take to repeal a law that has entitlements. So it's probably not going away no matter what happens. So macro will fundamentally change how we're paid. There are two payment options. One is the merit-based system where you have to do a whole bunch of things for incentive payment. And the second is alternative payment models. And here's the secret. If you're in academic medicine, you don't even have to think about this. It is completely under your radar. So all the scare tactics, all the things about this stuff, if you're in an academic medical system, it's done for you. Here are the alternative payment models. And here's where academic medicine in the next decade is really going to plant its flag again from a healthcare delivery standpoint. And what Keith said about creating a career in healthcare delivery and quality improvement, absolutely, the field's wide open. I mean, why would Yale pick somebody who's been in private practice for 27 years and bring them on as a clinical chief and professor of medicine? They get the fact that healthcare delivery is really an important thing. We talk about reference pricing. That's where they send people out to find a colonoscopy and give them a certain amount of money. Bundled payment, that's where a purchaser contracts with a provider for a bundled payment around colonoscopy. We're talking about episode payment for condition. We're already seeing that around Crohn's disease. And of course, we're headed towards total cost of care for some part of a health system's revenue. The typical change agents that we've talked about from a specialty standpoint really have been employers, patients, government, commercial health plans. But if you're a private practice right now, what you're looking at are things called clinically integrated networks, and here's what that is. This is a clinically integrated network, and this is where all of our health systems, in one form or another, are headed. You've got an insurance as a partner or component, because, of course, you have to incorporate all the different health services, and the only way you can do that is by administrative data. They're usually based in hospitals because that's where the money is. They have a strong primary care base with care coordination. They have an ambulatory network of skilled nursing homes and ambulatory surgery centers. And then their specialty network, there are two options. Either they're employed, like Kaiser, for example, or they're an affiliate, like Alina is affiliating with Minnesota Gastroenterology. It's still an open question as to which of those models is going to be predominant. And if the former is an employment model, then that'll be the end of independent specialty practice. Those are the kind of the tensions that community practitioners are dealing with. There are three market options for these clinically integrated networks, and the height of this bar tends to be the cost of delivering care, which translates into premiums. So you've got this closed restricted network that would be like a Kaiser model, fully employed. A second, an affiliate model where you've got employed primary care providers and affiliated specialists. Usually you've got employed cardiology, sometimes employed surgery, but a lot of affiliated specialists. And then you've got academic medical centers who have to deal with teaching and research, kind of a cumbersome patient experience, sometimes safety net hospitals. We are still in sort of a semi-metastable mode where most places are recognized for having a more expensive care delivery and are subsidized by purchasers. But that is changing. You can see that by looking at the partners' experience in Massachusetts, where their costs were 25% higher, and the Massachusetts Department of Health said, we're not going to take you as a provider. So that type of thing is changing, and so healthcare systems that understand this and really work to change that is really where you want to be. So academic medical centers. There are going to be some winners and there are going to be some losers. There are about 130 centers of medical education and research. And you know, 10, 20 years ago, when you came out and you're in your position, you say, okay, where's my best opportunity for grant funding? Where are my best opportunities for advancement? That's all still important, but unless you take in, as Keith pointed out and teed up for me, unless you take in the kind of the attitude and the environment of the healthcare system, you're going to potentially be in trouble. The great thing is that being in academics, you're fungible. You can go from academic medical center to academic medical center with relative ease. That's not really true in practice. And you can look at my experience where I'm at Yale now, and I'm presumably, unless John Carruthers retracts his offer, going to be at University of Michigan in the fall. So you can move within academic medical centers easily. They are competing head-to-head with nonprofit integrated delivery systems. Graduate medical education and disproportionate share hospital funds have been especially hit hard, so there are really beginning to be 5 options for academic medical centers. And when you interview, you need to understand what's what in terms of the place you want to work. So starting from the far left, an academic medical center can merge and affiliate with a mega system. There are very few and diminishing freestanding academic medical centers. They are now almost universally part of a larger system. So for example, Trinity, which is the largest Catholic healthcare delivery system, purchased Loyola. The University of Minnesota Medical Center merged with a sort of a community-based nonprofit entity called Fairview, and there are a lot of other examples of that I could give. You can also be a specialized complex care center. So this would be like CHOP or MD Anderson, where there's a very specific national and international reputation. That's another factor. A high-performing regional system. So that would be like Yale or Penn or some others like that, where they are so dominant in their market that they are relatively protected. You can be a public entity, University of New Mexico, for example, where I trained, or some University of Iowa. These are state-funded, state-subsidized schools. And then you have systems that are moving into what healthcare delivery is moving towards, which is really population health, developing a system and a network to really deliver care at a population level. And I would put UPMC, and I am hopeful that I'd put University of Michigan in that same arena. But if you're doing research, you want to understand where your system that you're potentially applying to is going and where it fits into these different entities, because your particular interest, your particular research may not fit one of these, but may fit very well in another. Everybody is talking about the value equation, and we've really emphasized the numerator. Well, guess what? Almost the rest of the world emphasizes the denominator. So the biggest opportunity in academic medical centers is if you're in there and you can decrease overhead in some way, you're going to be a star. Other point, big data rules. So most academic medical centers, most large healthcare systems are now moving towards either Epic or Cerner or something like that. And under Epic, you sort of exist in the Chronicles part of Epic. That's where we enter data. You've got a Clarity database, which is sort of a little mini database for analytics, but you've got an enormous enterprise data warehouse that has unbelievable population health capabilities. And so being an expert in your electronic medical record down at that level will make you invaluable. So the academic medical centers are the ones that are going to figure out how to care for populations. So if you look at this, here's a typical Crohn's patient. You see them at 9:30. You have the Sonic trial. You figure, okay, it's good for combination therapy. An academic medical center or a really well-integrated community practice will pull together all inflammatory bowel disease patients through the different ICD-9 and ICD-10 codes and do things like this: clinical decision support on preventive care, lab monitoring, patient engagement survey, red flag alerts, clinical algorithms and standardized order sets, after-visit data center registries, psychosocial care. This is where an academic medical center with a good, solid base of inflammatory bowel disease or liver or something like that will pull this together as a population, and you will have metrics, you will have clinical outcomes that cannot be matched. And if your academic medical center is thinking in these terms, that's where you want to be. There are a lot of point-of-care clinical decision support tools and patient-reported outcome metrics now, and there are a lot of ways to input that, either through MyChart, kiosk, or mobile apps. They go into a healthcare system. You want to start building epic interfaces through the web with interactive templates, clinical decision support, and then you want to be able to, again, feed into some sort of recognition registries. These systems are being built rapidly as we speak. But the main thing is you only want your physicians to interact at a single point in a facilitated, easy way to enter data. So as you start interviewing, as you start thinking about this, start asking about their IT systems. Start asking about how they're leveraging that to really do population health. Chronic care model. You can't have a practice where you just see one patient after another anymore. That just is not going to cut it. If you think of a Crohn's patient, for example, or any chronic disease patient, they fall into 4 different categories. They're the ones that have Crohn's, but they're relatively healthy. They're ones that are worried well. They're ones that are about to fall off the cliff for a variety of reasons. And they're one that just never quite get better. So you really have to construct your care delivery around that concept. And again, you want to be in that type of system. Here's why. We're going to end up with about 5 to 10 top-tier preferred referral centers. And there are a number of centers around the country. Mayo Clinic's classic in this, Cleveland Clinic's classic, Hopkins is classic, who really are trying to get both national medical tourism and international medical tourism to come to them, first of all, based on excellent quality, but also on bundling procedures and lowering costs so that a big employer, for example, would really have no other option. So we're going to end up with about 5 to 10 that are recognized in that sphere. There are going to be lots of regional centers of excellence that are really pretty good but may not have the reach. And there are going to be a few other large clinically integrated networks that are going to probably struggle. And again, as an academic medical center, you really want to be in that top tier. The NIH support is being funneled into a few institutions. We're going to have at least a 2-tier system in terms of academics. So here are the top 12. You can't really read them over there, but they're pretty much what's in this room. So you're going to have a few institutions with good, solid NIH support or other philanthropic support, and then you're going to have other systems that are part of health systems that really treat them as, first of all, a marquee, but also really as an apprenticeship for clinical learning. Not bad, but you have to understand, where you are and what you want. The reason why this is important, even at Yale, which is one of the most research-heavy institutions, if you start back in 2001, that top green line was their research revenue, the second line was their clinical revenue, the third line was philanthropy, and the fourth line is tuition. So tuition's going nowhere. Philanthropy is easing up a little bit, but the growth at Yale over the last decade has been almost solely in clinicians. And that line crossed now in 2012, where even Yale derives more of its revenue from clinical sources versus research sources. So the emphasis on clinical productivity is intense. So successful academic medical centers will adapt to change. It's not how to align, it's whether to align, it's how to align, not whether to align, particularly with community groups, with other centers, for example. You need MD leadership that understands how to integrate in with hospital management. You need business people. You need to be in a system where if you're a beginning faculty member, you can be assured that the leaders of that institution get this and are well integrated into the business of the healthcare system. You have to understand leadership of a multidisciplinary clinical teams, that we're moving towards that. The collaborative, organized medical staff. You have to really bring your medical staff together, understand the imperatives of healthcare reform, and move towards that. So that's the culture that you want to choose. And again, scholarship on clinical improvement, clinical integration is going to be key. So here are your choices. You can academic medical center, about 2,000 clinical gastroenterologists, either research or clinical. You can be in community practice, about 10,000 in multi-specialty group practice, or in independent. There's a marked shift from the left to the right, and we're seeing the development of multi-state community practices, and moving towards clinically integrated network. And the key, since I made this slide a few years ago, is that academic practices are moving into that lower right corner as well. So this just came out in this month's Gastroenterology, the Gastroenterology 2020 No Time for WIMPs. So WIMPs are weakly interactive massive particles. It's dark matter of the universe. And we have been the gastroenterologists have been weakly interactive with healthcare systems. We've fled to our ASCs, we've concentrated on high-throughput colonoscopy, and that's changing. We have got, whether you're in community practice or academic practice, we have to think and have strong relations with healthcare systems. So I hope that laid a foundation of some of your thoughts about how you develop your practice, and I just want to end again by emphasizing the 3 points. There is no time better than to go into academic medicine, because community practices are on a bubble, and what you want to do is you want to short them. The second is that you are the elite of the elite, and there is no barrier to how far you can rise. And the third, be judicious about where you choose to work. Thanks.